So I'm called upon in the stage Dr. Ahmed Awadein for his presentation.
Thank you. I'm Ahmed Awadein. I'm professor of ophthalmology in Cairo University, Cairo, Egypt. I'm specialized in pediatric ophthalmology and strabismus. And my presentation today will be about a particular type of muscle transposition, the Nishida and the modified Nishida procedures. So various types of muscle transpositions have been proposed for the management of different causes of paralytic and restrictive strabismus. We're all aware of the full tendon transposition, as well as the split tendon transpositions, such as the Janssen and the Hummelsheim procedure. Recently, the Nishida and the modified Nishida procedures have been introduced as an alternative to transposition procedures. In the Nishida procedure, the superior and the inferior rectus muscles are split longitudinally along the length of the muscle, but without disinsertion of the muscle. Then the temporal halves of the superior and the lateral and the inferior rectus are sutured and fixed to the sclera approximately 10 millimeters from the limbus, just above and below the insertion of the lateral rectus muscle. In the modified Nishida procedure, it's performed exactly in the same way as the Nishida procedure, but this time without splitting of the muscle. You just pass the suture through the temporal border of the superior and the inferior rectus, and then suture and fix the muscle to the sclera above and below the lateral rectus, approximately 12 millimeters from the limbus. So this is a video demonstrating the modified Nishida procedure. This is the lateral rectus muscle. We are hooking it through an infratemporal incision, and then we are marking a point on the sclera approximately 12 millimeters from the limbus, just below the lower border of the lateral rectus muscle. Then a non-absorbable suture is then passed through this point, and then the inferior rectus muscle is then hooked, degloved, and dissected from the surrounding tissue. And then the same suture is passed through the temporal border of the inferior rectus, approximately 8 millimeters from the insertion. The two ends of the suture are then pulled together to approximate the muscle and fix it to the sclera just below the lateral rectus muscle. So we don't need to do any splitting or disinsertion of the muscle. Then the same procedure is repeated for the superior rectus muscle. A supratemporal fornix incision is performed in order to explore and identify the superior rectus and the lateral rectus muscle. This is the superior rectus muscle. It is hooked and then degloved and dissected from the surrounding tissue. The intermuscular septum is opened, and then the superior rectus muscle is meticulously dissected from the overlying tissues, in particular from the levator aponeurosis, because you don't want to induce changes in the palpebral fissure with such type of transpositions. You need to meticulously dissect it from the levator aponeurosis as well as from the underlying superior oblique muscle. Then again you hook the lateral rectus, but this time from the upper border, and then you mark a point about 12 millimeters from the limbus, just above the upper border of the lateral rectus muscle. Again, another non-absorbable suture is passed through this point, and then we go back to the superior rectus muscle that we already have dissected it from the surrounding tissue, and then we pass the same suture to the temporal border of the superior rectus muscle, about 8 millimeters from the muscle insertion. And as we did with the inferior rectus, we pull on the two ends of the suture in order to pull the muscle towards the lateral rectus muscle. And this is the final appearance of the muscle, with both the superior and the inferior rectus muscle just above and below the lateral rectus belly. So the main indication of a Nishida procedure is in fixed nerve palsy. The advantages and the presumed advantages of the Nishida procedure is that it is technically easier. The procedure can be performed just by passing a suture through the sclera and the muscle belly. You don't need to do dissect, you don't need to split the muscle or to do any kind of splitting of the muscle. So technically the procedure is much easier to perform. In addition, because no muscle disinsertion is performed, there is a lower risk of anterior segment ischemia. However, I have to admit that there has been a report of anterior segment ischemia even with the Nishida and modified Nishida procedure. Moreover, the technique is also more potent. You can achieve a correction of about 25 to 30% diopters correction of horizontal deviation as compared to the 20 and 25% correction that you obtain with other types of split transposition such as the Janssen and Hummelsheim procedure. And this would presumably result in a larger binocular field of vision. So we have Some examples here. This is a patient who presented with 6-nerve palsy with an esotropia of 45 prism diopters and the -5 limitation of epiduction. And this is the patient after performing a medial rectus recession together with a modified Nishida. You can see that the achievement of a good alignment in the primary position and improvement of the epiduction. Now this is another patient with an esotropia of 45 prism diopters and less severe limitation, just -4 limitation of epiduction. And again, you can have a good alignment after surgery and improvement of the epiduction. And in another patient with an esotropia of 30 prism diopters and -5 limitation, this is a traumatic 6-nerve palsy. Again, you can achieve an alignment in the primary position and almost restoration of the abduction, just like -1 limitation of abduction in this patient. In addition, the Nishida procedure is more self-adjusting regarding the overcorrection. So what do we mean by self-adjusting? This is a patient who had a traumatic right 6-nerve palsy. She had a modified Nishida procedure and a medial rectus recession. You can see that immediately after surgery, like 1 week after surgery, she had significant overcorrection of about 25 prism diopters of exotropia. But if you just waited enough just for 2 months, you can find that this overcorrection just disappears on its own without any need for surgical intervention. Now, this is another patient who presented with a 6-nerve palsy and a -4 limitation of epiduction. Again, after just performing a Nishida procedure, he had a significant overcorrection, about 30 or 35 prism diopters of exotropia. And again, without any secondary intervention, just by waiting for 2 months, you can see that this overcorrection disappeared completely with improvement of the epiduction. The procedure is also more self-adjusting regarding induction of vertical deviation as compared to other types of transposition. So this is a patient who presented with a right 6-nerve palsy. He had a modified Nishida procedure and a medial rectus recession, but after surgery he had a hypertropia in the eye that we did the transposition in. This is the appearance 1 week after surgery, and if you see the patient 1 month after surgery, you can find that most of this hypertropia disappeared completely without any secondary intervention. So this is always the beauty of the Nishida procedure, that it just self-adjusts on its own even if you get an overcorrection of a vertical deviation. While the most common indication is of modified Nishida is 6-nerve palsy, the indications have extended to include even cases of monocular elevation deficit, whether the congenital type or the acquired type. This is a child who presented with a congenital monocular elevation deficit with a significant right hypertropia and limitation of elevation both in epiduction and adduction. So in this case, we performed a modified Nishida procedure on the medial and the lateral rectus by transposing the medial and the lateral rectus muscle towards the superior rectus without splitting and without this insertion. You can see that 1 day after surgery, the patient had some overcorrection with hypertropia now in this eye. We also performed a medial rectus resection on the left side to correct for the exotropia. And you can see that over the next few weeks, the hypertropia started to improve on its own, this overcorrection. This is 1 month after surgery, and 3 months after surgery, you can see that we have no overcorrection and we have improvement of the elevation, particularly in adduction. This is another patient with an acquired monocular elevation deficit. Again, he has a hypertropia and limitation of elevation in abduction and adduction. We transposed both the medial and lateral rectus muscle towards the superior rectus with achievement of a good alignment and improvement of the elevation in abduction and adduction. We can do the same procedure for inferior rectus palsy by transposing the medial and the lateral rectus, but not to the superior rectus, towards the inferior rectus muscle. This is a child who presented with a traumatic left inferior rectus palsy with limitation of depression of the left eye. And you can see that after performing a Nishida procedure, you have a good alignment and improvement of the depression in abduction. Another patient with a traumatic partial third-nerve palsy with a hypertropia and limitation of depression. And after performing a modified Nishida, you have a good alignment and improvement of the depression. Finally, Nishida procedure can be performed in the medial rectus paresis, however, it's much less effective in these cases. This is a patient, 32 years old, who had a history of a fungal ethmoidal sinusitis that was surgically debrided and removed 3 times, but was complicated with enophthalmostosis and exotropia. He had a liberal recession of the lateral rectus together with a conjunctival recession and exploration and advancement of the remaining medial rectus muscle fibers. However, post-operatively, he was still undercorrected after surgery. You can see that he did not get a much more improvement. So what we did is we did a modified Nishida procedure by transposing the superior and the inferior rectus muscle towards the medial rectus to improve the adduction. You can see that the alignment has improved, but still we are markedly undercorrected and we still have limitation of adduction. We had to fit the patient with a Fresnel prism to compensate for the residual exotropia. Another patient who presented with lost medial rectus muscle following an early childhood surgery, and again after performing a modified Nishida procedure, you see that the patient is still undercorrected and we did not achieve a satisfactory correction. So why is Nishida less effective for medial transposition? Because contrary to lateral transposition, medial transposition of the superior and the inferior rectus muscle does not put enough stretch on the muscle to aid the transposition. The medial transposition of the superior and the inferior rectus muscle, when performed, should be augmented with resection, which is not possible in the Nishida procedure. Thank you for your listening.
Thank you, Dr. Ahmed, for such an illuminating presentation. That's really a new technique.